Thanks, Dr. Sumitra, for giving me this opportunity. I would be talking on the challenges in monitoring advanced glaucoma. All of us are fully aware that the glaucoma is divided into mild, moderate, and advanced glaucoma. Glaucoma is a chronic progressive disease and it has to be monitored very meticulously. If you do not monitor the disease meticulously, then it is likely to progress and may cause blindness. Monitoring the mild, moderate glaucoma is not very difficult. Monitoring advanced glaucoma is not also very difficult, but monitoring very advanced glaucoma is very difficult. So in this talk, I am going to cover how to monitor very advanced glaucoma cases in your practice. Mind it, because glaucoma is a silent killer of vision, very often you get the patient who have very advanced glaucoma. It is also called as a late or end stage glaucoma. So this is the classical definition of glaucoma. You have a classical glaucomatous optic neuropathy with correlating visual field changes. No one would have any problem in monitoring these cases if there is a good compliance, if the patient comes to you for a regular follow-up. Obviously, you can monitor, you can pick up the progression at any stage, and you can modify your treatment strategy, and you can prevent the patient from landing up into irreversible blindness. But the real challenge is to monitor the end stage or a very advanced glaucoma. The reason is that what modalities you have to monitor the glaucoma. Glaucoma can be monitored by doing the stereoscopic disc photograph. In very advanced stage, where there is no neuroretinal rim, you cannot observe the progression just by taking the stereoscopic photograph. The second equipment is OCT or any imaging device. Other imaging devices are not available, it's only the OCT. OCT has its floor effect, we will discuss subsequently. So you cannot monitor a very advanced glaucoma based on the OCT. So you are left only with your gold standard perimetry, but there are also n number of challenges in monitoring these glaucomas even on the perimetry. Why? That you would be knowing. This glaucoma is a very early glaucoma, very easy to monitor, and I'm sure that if the compliance is good, then this patient will never ever end up in blindness. But this glaucoma, you have a very small breathing space, and whatsoever he has got, whatsoever is remains, you have to preserve it. Then only patient would be having a functional vision, and he will not be dependent on any of his family member for his routine day-to-day activities like having a food or taking bath or going to lavatory and so on and so forth. Otherwise, 24 hours attendant are required. So this is one of the case. You can see that there is almost a total cupping, and you can see that very, very small narrow island of vision is left. Dr. Das was discussing about that. Some of these patients are very intelligent, and through this very narrow island of vision, they have a reasonably good vision. Remember that that is just a vision. The quality of vision is poor, very poor, but still if they are able to focus the television or if they are able to focus any object, they would be able to do the activity, and once they move the face, they miss the object and it becomes very difficult. So monitoring these patients is very difficult, but we have to save the vision somehow. If you do the perimetry on a standard 24 days 2 or 30 days 2 program, you do not get any information out of it, because even the perimetry has a floor effect, where only couple of decibel are left, then what you would get or what you would interpret it out of it? Nothing. Same thing is true with the OCT. Because of the glial tissue, because of the blood vessels, the floor effect in the OCT comes at pretty early stage, and below 40 micron, you cannot pick up any defect, and you have to leave it like that, and perimetry is not at all useful in all those patients who have the RNFL thickness less than 40 micron, so the perimetry is useless. So what to do? If you have these kind of a small field, you have to find some strategy, and yes, all the perimeters are equipped with various strategies. The one is that you can use the stimulus size 5, that's a bigger object, and if the bigger object is there, if the patient has a poor vision, then also they would be able to pick up. But there is a problem with the strategy 5, you cannot do the progression analysis. But you are equipped with another strategies, that is 10-2. If you do the 10-2, then obviously, yes, you would be able to pick up very small defect also, and that defect can be monitored for progression as well over a period of time. The difference between 24 days and 10-2 is that there is a resolution of 6 minutes if you have selected a strategy of 24 days 2. But there is a resolution of 2 minutes if you have selected the strategy of 10-2. There is a huge difference. But 24 days 2C is not useful in that, because they just have 10 additional random points, so they do not increase the resolution of the test you get. The total number of points you test is 68 as compared to the 54 points in 24 days 2. And see the difference. It's a very small field, and when you do the 10 days 2, you get a much better information to interpret. That is the important. Here you test only 12 points where 40% of the ganglion cell lies. And here you test 58 points where 40% ganglion cell lies. So obviously testing 58 points in the central 10-2 is more important than testing just 12 points. And remember that, you know, the spot size 3, almost 230 ganglion cells function can be assessed by one single point in the central area. While in the peripheral area, it's only the 10 ganglion cells are present for stimulus size 3. So obviously the central area is more important for all advanced glaucoma. And any single decibel deviation in 3 consecutive points is significant. And even if you have a very advanced case, then mean deviation, if deviated by 1 decibel, then also consider as a significant. And you can monitor these patients for a smallest progression, and you can preserve that vision that patient has got. So in summary, the visual field assessment is very critical. But remember, if you have a patient of end-stage glaucoma, then the 10-2 strategy is the best strategy. You can monitor the glaucoma and you can pick up the progression little early, and probably you would be able to save a useful vision the patient has got.